My patient is a 62-year-old man. He was an ex-smoker, non-drinker, known hepatitis B carrier, but he did not have any regular surveillance, and he was not on antiviral therapy. He presented with abdominal distension to a regional hospital in Hong Kong. And on examination, it shows gross ascites. We performed paracentesis for him. 5 liters of ascites was drained. It was transudative, and he has no evidence of SVP. On admission, his biochemical tests are listed in the table with a bilirubin of 16, normal liver enzymes, 31 albumin, platelets only 97, INR 1.1, and a normal creatinine level. His alpha-fetoprotein was more than 100,000. With his blood tests and clinical ascites, his child score was 7 and is a child class B patient. And we performed a contrast CT scan for him because of the high alpha-fetoprotein and found there was a very extensive tumor over the left lobe with bilateral portal vein thrombosis. So the portal vein thrombosis extended from the left and then to the right, and also there was portal vein thrombosis in the main portal vein. And because of the large tumor, high alpha-fetoprotein, we performed dual tracer PET CT scan for him to rule out metastasis. And in Hong Kong, we use a dual tracer. That means an FDG plus C11 acetate as the tracer options for HCC patient because it would increase the sensitivity when compared to FDG scan alone. And for our patient, the tumor and the portal vein tumor thrombi also showed diffuse uptake with FDG and C11 acetate, but there was no distant metastasis. So at this juncture, we thought of the treatment options. I think for transarterial chemoembolization, TACE is contraindicated because of the main portal vein thrombosis. Ablation, either radiofrequency, microwave, or whatever, would be too extensive for a large tumor with tumor thrombus. Theoretically and technically, it is possible for a elective hepatectomy with portal vein thrombectomy. But this patient has poor liver function and portal hypertension to start with. The risk of post-hepatectomy liver failure was very high. Liver transplant is an appealing option because it treats the tumor and also the underlying cirrhosis, but is a very, very beyond standard criteria. And in some centers, especially in United States, I think Y90 or in Singapore, they actually had a lot of experience with Y90 radioembolization. It's very often used to treat large tumor with portal vein tumor thrombosis. And if in the literature, if we follow the BCLC staging for these patients, probably they will end up with systemic treatment. I think the current standard would be combination of a TISO bath, that is immunotherapy plus the antivascular endothelial growth factors. So remember, when we treat HCC patient, we are treating one patient with 2 diseases. And I think in this patient, he had a highly malignant tumor, rapidly growing, and HCC also has a high propensity for vascular invasion, and very often, like in our patient, is associated with cirrhosis and impaired liver function. So our hands are often tied by the treatment option and also the baseline liver function of our patients. So if liver transplant appears to be the best solution for the patient, but we could argue if we transplant someone with a predicted poor survival because of the large tumor and portal vein thrombosis, then does it justify the risk of a living donation? Or if we want to allocate a disease organ to this patient, the question became, does it justify the allocation of a precious organ? So it became a philosophical question of what is a acceptable survival for HCC patient after transplant. I think in the past, it is based on a consensus statement that the minimum accepted survival for HCC should be at least 50% at 5 years. And previously, there was a publication based on a Markov model that says the adverse effect of transplanting someone with very extended criteria HCC would outweigh its benefit if the expected 5-year survival was less than 61%. So I think in the latest ILTS consensus statement, we have increased the benchmark a bit further, that the 5-year survival should be at least 60% in the background of a low donor complication. So for our patient, this is a very nice study from India. They look into their outcomes of transplanted HCC patients, 451 of them. 46 patients had HCC with portal tumor thrombus. They compared the outcomes to HCC alone without tumor thrombus for around 405 patients. The predictor for recurrence would be a high alpha-fetoprotein before transplant, tumor beyond UCSF criteria, and PET positive on the PET scan. So if patient had only one poor prognostic factors, the risk of recurrence at 5 years is less than 10%. If the tumor was PET positive plus either beyond criteria or high alpha-fetoprotein, the cumulative risk of recurrence became 25%. So for patients with all these 3 prognostic factors, high alpha-fetoprotein, beyond criteria, and PET positive, the recurrence risk would be over 50% at 5 years. And also the degree of tumor thrombosis would matters. In our patient, it's very extensive main bilateral portal vein was involved. But in a publication from South Korea, if they only look at patients with segmental portal vein tumor thrombosis, that is very distal portal vein branches, the 5-year survival is actually over 60%. And the risk of recurrence is around 50% at 5 years. So transplanting this patient will still be considered acceptable. When compared to those with main portal vein or left or right hepatic vein thrombosis, then the risk of recurrence and survival would be only 14% at 5 years. Then it would not justify the risk of a living donation. So a short summary for our patient: large tumor, bilateral and main portal vein thrombosis, PET positive, high alpha-fetoprotein. So it doesn't justify an upfront transplant. So what we ended up opted for this patient is downstaging. So what is downstaging? It means we try to utilize local regional treatment to reduce the size and numbers of tumor so that they would meet acceptable criteria for liver transplant. The tumor response assessment is usually based on radiology, based on the modified RECIST criteria. That is, we only count the viable tumor where the area of necrosis is not considered. And it's been used as a selection tool for tumor to identify tumor with more favorable biological behavior. And those are the patients who would do well after transplant. So the most famous downstaging criteria would be the UCSF downstaging criteria with one tumor up to X centimeters, and also could include patient up to 5 tumors. After successful downstaging, the 5-year survival is close to 80% with a 10% recurrence rate. So it's very similar to patients within the Milan criteria. So it has become the US national policy. And this is a publication by a US multicenter analysis. So if we could successfully downstage the tumor to within the Milan, actually the long-term survival is very similar to patients within the Milan criteria. So can we push the envelope a bit further and try to downstage HCC with main portal vein tumor thrombus? So this is a multi-center study from US and Europe. It was a small study with a highly selective group of patients. And in literature, we classified the degree of tumor thrombosis according to the liver cancer study of Japan criteria. VP4 means main part of vein thrombosis. Right and left part of vein would be VP3. And segmental branches would be like the anterior, posterior part of vein would be VP2. More distal branches would be VP1. In this study, they included patients with VP1 to VP3. That means not those with main part of vein thrombosis. And after successful downstaging, the endpoint is complete radiological response on imaging. With a median time from successful downstaging to LT close to 1 year, they were able to demonstrate a 5-year survival of around 60%, which is, I think, the best that we have so far in literature. So in our patient, he is not within the Milan. He doesn't belong to UCSF downstaging protocol. He belongs to what we call all comers. That means there is no restriction in the tumor number and tumor size. As long as there is no extrahepatic disease, then they could try to receive downstaging therapy. So what's the downstaging option? In literature, the most common downstaging option would be TACE or RFA. In our center, previously, we have published our series on high-intensity focused ultrasound, but it's not commonly carried out in the rest of the world except China. The Northwestern group from Chicago has a lot of experience with Y90, and in our center, we use stereotactic body radiation therapy, SBRT, plus or minus systemic treatment. So in our previous study, out of 40 patients, we enrolled them to receive SBRT as bridging therapy for transplant. When compared to conventional bridging therapy such as TACE and HIFU, the tumor control rate was around 90% at every time points, 3, 6, 9, and 12 months after bridging therapy, and is better than TACE or HIFU. In comparing risk analysis with the use of SBRT, the risk of waitlist dropout was much less when compared to TACE and HIFU, but it's still not perfect. The risk of delisting is up to 20%. So in our patient, besides SBRT, we want to have something that could help with the portal-vein tumor thrombosis and prevent the tumor from extrahepatic metastasis. So we look into a study that was also performed in our group. We use a combination treatment in locally advanced and resectable HCC patients they were not candidate for curative treatment. So we gave TACE, SBRT, followed by immunotherapy. And in this study, we were able to achieve a 12% of the patient were downstage to curative treatment. 42% of the patient had complete radiological response. So from our experience, we believe the therapeutic effect is from the SBRT and immunotherapy. So for our patient, he had SBRT followed by 6 months of immunotherapy. And you can see on subsequent CT scan, there was evidence of decompensation. He had worsening ascites. The liver was shrunken, but the tumor was no longer contrast enhanced. And the tumor size was reduced, and also the alpha-fetoprotein level was normalized. So we offered a right-lobed LDLT for him. Donor was the patient's son. In the explant, the left lobe was atrophic, and the tumor was only 1.5 centimeters. Majority of the tumor was not viable, and it was a moderately differentiated HCC. For the portal-vein tumor thrombus, there was no viable tumor. So concerning the role of systemic treatment in pre-LT setting, I think there's very limited data in this area. The small randomized controlled trial from Hoffman was the only one that I could find in the literature on the use of TKI. But in this paper, they used sorafenib for tumor control before transplant. Unfortunately, there was no difference when compared to placebo. And also there was another publication that reported the use of sorafenib before transplant might be associated with a higher risk of biliary complication and acute cellular rejection. So there wasn't a lot of interest with sorafenib. So what about the role of immunotherapy? I think, again, very limited data because of the early reports of fatal hepatic necrosis and rejection after anti-PD-1 therapy before transplant. And recently, the group from Mount Sinai in New York, they reported 9 patients who underwent liver transplant and they have been treated with nivolumab. And in the series, there was no severe rejection, graft loss, recurrence, and death, with a median follow-up of 16 months. And 1/3 of the tumor actually showed complete necrosis in the explant. So what contributed to the success of utilization of immunotherapy, I think, is for the timing. And And in another report from the United States, 5 patients received nivolumab, 2 developed severe hepatic necrosis and biopsy-proven acute cellular rejection. And both of these patients, the most recent dose of immunotherapy was within 3 months before transplant. And in another case series from China, 16 patients who received different PD-1 inhibitors, like nivolumab, pembrolizumab, sintilimab, around 60% of them developed early rejection, and they noticed the risk of rejection was related to an interval of cessation of immunotherapy of less than 60 days. So in our centers, we stopped the immunotherapy for 3 months before liver transplant because the half-life for immunotherapy is around 6 weeks. So I think there are 2 ongoing trials that look into the use of immunotherapy plus TKI inhibitor in HCC before transplant and also for locally advanced tumors that would give us more data on the safety and efficacy. So this is a publication from the MERIT-LT Consortium. It's a multi-center collaboration on downstaging HCC in the United States. Previously, they only utilized local regional therapy for downstaging, but in their latest publication that would be out very soon in Hepatology, they incorporated the use of immunotherapy in patients who did not achieve complete response after local regional treatment. The first line would be atezolizumab. In those who cannot tolerate atezolizumab, it will be pembrolizumab or nivolumab. And in all of these patients, they would aim to stop the systemic treatment around 12 weeks, that is 3 months before transplant. So for our patient, it's been 8 months after transplantation. He had normal graft function. He's maintained on Prograf, a CNI inhibitor, and everolimus, an mTOR inhibitor as immunosuppression. The alpha-fetoprotein remained low, and with his latest CT this month, it shows no recurrence. So with this, I would like to thank you for your attention.
Thank you, Professor Tiffany, for a nice presentation. A very successful story of a very sick patient coming with advanced disease, and then finally you could rescue him. So I would like to now request the audience for any questions. I can't see any question in the chat box.
Yeah. Professor Tiffany, one more thing. I know you are a transplant surgeon. So what about the everolimus in these particular patients? Because we know that for the post-transplant SCC recurrence can be prevented or reduced by consideration of everolimus. But what should be the dose and what should be the target level and how it should be? It is with everolimus dose, how to be adjusted. So I just need to know the immunosuppression adjustment you do particularly for the SCC cases?
Oh, yes, for HCC patient, I think in previously, there was a randomized control trial to look into the use of mTOR inhibitor and see if we could reduce HCC recurrence. Unfortunately, that trial was negative. So in our center, in patient with tumor, whatever HCC, colorectal, lymphoma, or cholangio, we try to keep the CNI low. Usually for other patients, we aim for a trough level of 5 to 8 in the first 3 months after transplant, and then around 5 afterwards. And for HCC patient, we would start everolimus, the mTOR inhibitor, 1 month after transplantation, and then we would reduce the dosage of Prograf, aiming for a just detectable, that is a trough level around 3 for the CNI. And for the everolimus, usually it is also around 3 to 5. And in our center, we don't use prednisolone as immunosuppression. So literally Prograf and everolimus.
Okay, thank you.
Professor Tiffany, one question from my side. You chose SBRT over TARE. In most of the cases with PVTT, in many Indian centers, they try TARE first and then go for another therapy. What was the reason behind choosing SBRT in your particular case?
Yes, this is a very good question, and I got this is not the first time that I got asked about like comparing SBRT and TARE. In Hong Kong, because we are a government-funded hospital, so the government has a very stringent criteria for TARE. So mostly is for patients with very advanced disease, and the waiting time for TARE is very long. So I would say TARE is available, but we are very difficult to get it done in Hong Kong in public setting. So we don't have a lot of experience with TARE. But if you look into the publication from other centers, I think TARE is very, very promising. So I think, and also in a lot of publication like the multi-center trial that downstage the portal-vein tumor thrombosis, I think they use a combination of TACE, SBRT, TARE. So I think the message is whatever you do, it should be a local regional treatment, perhaps plus a systemic treatment for patient with tumor thrombus. So if you are more experienced in TARE, then you can go for TARE. So the most important thing is the downstaging endpoint, that we should achieve complete radiological response.
Thank you very much.
Hello.
Hello.
Yeah, ma'am. It's a nice presentation. I just want to add one thing, that in our centers, that ILPS India, so we are also doing SBRT for PVTT and seeing good results post SBRT. So we are combining it with TACE, SBRT followed by TACE if required. So the results are very similar to what you have shown.
Yes,
So
I
we
think
are also
SBRT is very, very effective.
Yeah, especially for PVTT, VP4, VP3 tumor thrombosis, SBRT is a better option. Thank you.
Yeah. So here one more thing also. Do you think SBRT, both Dr. Dipti as well as Dr. Tivani, so do you think that SBRT will cause more immunoexpression so that the subsequent immunotherapy will be more helpful in that way?
Yes. I think for SBRT, by combining SBRT immunotherapy, I think there are many reports that said once you perform SBRT, you kind of sensitize your immune cells, and it is more sensitive for if the immune cell would be sensitized, so it would be more responsive to immunotherapy. And yes, we believe it is the case. So for locally advanced tumor or for downstage therapy, combining SBRT and immunotherapy is our preference now.
And
Yes,
one more suggestion.
sir.
Yeah.
Yeah,
Please,
we have
Dr.
also
Dipti.
seen good responses post immunotherapy. Now there's a hypothesis that if we give radiation therapy of single fraction, and after that, after about 10 days, if we give atezolizumab, bevacizumab, or any other immunotherapy, so means it acts as a therapeutic vaccine, in vitro therapeutic vaccine as well. In vivo therapeutic vaccine by combining the SBRT followed by immunotherapy.
Yeah. So I think one more thing, Professor Sina can say, or Taiwan, Professor Liu, where the cadaver transplant is more happening. So could you take this patient for transplant who is a beyond criteria but responded to downstaging treatments? Were you going to take this patient for transplant or no?
So sorry, can you repeat the question? What is the patient?
So is your approach for a transplant in lab or a cadaver centric approach different or will be same?
Oh, sorry, I don't get it. Yeah.
Sorry, suppose because this is a patient who got treated, he's responded. So you have the donor, you have go for immediately transplant. But this is a patient who is beyond criteria, you have been downstage. So he will be in a cadaver setting for the transplant. A robust transplant program is mostly DDLT. So how he will get the graft? Is there going to be, because we know that you have to wait for 3 months for the tumor biological behavior. And this patient may not give a long time for these things to happen. So would we wait for a cadaver to be transplanted with a risk that the tumor will progress? How to manage? Or you will give some priority so that he can get a cadaver at the earliest?
I think in the United States, it is difficult for deceased donor setting because you cannot predict the graft. I think how they get around it is they give immunotherapy, usually for 6 months, but they look into their center's waiting time. So for us, it's around 1 year to 1.6 to 1.5 years. So we kind of know, and then all these patients, they reach the top of the deceased donor waiting list by mild exception. That means you increase the point month by month. So when they almost reach the point of 1 year, then we will stop the immunotherapy. So yes, that there is a problem that in between transplant and you stopping immunotherapy, there would be a gap where they do not have anything at all. In some centers, they will switch to a TKI, like lymphatinib, because the duration of lymphatinib to transplant is much shorter. So in some center, they would switch to lymphatinib. In our center, because for all these patients, we only offer living donor liver transplant. So is the time sensitive issue is not a concern for if you have a live donor. But for Western countries or for a deceased donor program, yes. I think you need to look at your center's waiting time and then kind of approximate your time with immunotherapy. And I think for patients who have complete radiological response, those with very excellent response, they should be given some sort of priority on the wait list.
Professor Sina, Professor Sudhanshu, Dr. Singhal was supposed to give the next lecture, but because of this confusion, he is not able to upload his links or recorded the videos. And we hope now we have to carry the discussion or we have to close the session as you guide. Professor Sina, please.
So now we need to so maybe so next month we will have the Oh,
Okay.
no, I'm sorry. So, this time we don't have the second part, so we have to close now. What do you?
Yeah. Okay. We'll close it.
Yeah.
Okay.
So thank you very much for the APASL webinar today. So I hope you enjoyed very much the talk with by Dr. Tiffany Wong. Thank you very much.
Thank you. Bye bye.
Bye bye.
Bye.